let's look at alterations in body systems. We're looking at anemia, angina pectoris, COPD, congenital heart anomalies, heart failure, hemophilia, hypertension, peripheral vascular disease, pneumonia, and sickle cell. With anemia, the body lacks enough healthy red blood cells to carry adequate oxygen to the body's tissues. So you will notice someone who has anemia feels very tired and weak. There's a decrease in the number of erythrocytes or a reduction in the hemoglobin. So what would you see in your clients? For clients who have mild anemia, you would normally see a hemoglobin level of between 13 to 18 grams per DL in males. They are usually asymptomatic when they have these levels, or the range is within these levels. And symptoms usually follow strenuous exertion. So you will notice palpitations, dyspnea, and excessive sweating. That will be your diaphoresis. But in moderate cases, or in moderate clients, or clients who have moderate anemia, you're going to see dyspnea, we'll see palpitations, there'll be diaphoresis, and there'll be chronic fatigue in these clients. With severe cases, you're going to see the client is pale, is exhausted all the time, so you see feeling weak or tired all of the time. There'll be shortness of breath. There's increased susceptibility to infection. There will be pallor, there will be cold hands or feet, or sensitivity to cold. The client would also have severe palpitations. They could have loss of appetite or pica. There will be profound weakness, like we already said, and there's that dizziness and syncope, and also headache. Complications from anemia could be cardiac complications, where you will have congestive heart failure and even angina pectoris. Again, our plan for this client would be to identify the cause of anemia. What is causing this client to be anemic? Remember, it could be as a result of red blood cell loss, maybe from sudden bleed from trauma, or bleeding from GIT system, for example, in a client who has ulcer. Anemia could also be caused by red blood cell destruction. You could see that in immune-mediated body attacks of the red blood cells, or destruction from infections or parasites and all of that. Anemia could also be as a result of decreased red blood cell production, seen in cases as bone marrow disease, cancer, kidney disease, and chronic disease. So want to identify the cause. Again, want to provide frequent rest periods for this client. You also want to frequently turn and position your client to help with his breathing. You also want to place him on diets high in protein, iron, and vitamins. Remember the role iron plays in production of red blood cells. We also want to give him small, easily digestible meals. We want to carry out good oral hygiene. If he has to be transfused, you want to monitor blood transfusions and protect from sources of infection. With angina pectoris is actually a medical term for chest pain or discomfort due to coronary heart disease. Okay, so this is a portion of the coronary vessel that has been expanded, and you can see there's plaque in the coronary artery. So there's insufficient blood flow to the heart muscles as a result of the narrowing of the coronary artery, and this could cause the chest pain, which we refer to as angina pectoris. So what would you see in your client? There will be pain. This pain can actually radiate down the left arm. There could also be arm pain that's associated with stress or exertion or anxiety. And this pain is relieved with rest. It's also relieved with nitroglycerin. And this is actually a warning sign of an impending ischemic event. So you want to intervene appropriately. So what are the risk factors for coronary artery disease? We have the non-modifiable risk factors. So these are the ones the client has no control over. And there are also the modifiable risk factors. These are the ones the client can actually exercise some form of control. In terms of non-modifiable factor, your age, you can't do anything about that. You don't have any control about that. Increased age is a risk factor for CAD or coronary artery disease. If you have a family history of coronary heart disease, it also puts you at a higher risk level. Men are also more likely, in terms of sex, men are more likely to develop heart disease than premenopausal women. And also your race, example, being Black or of African descent, places you on a higher risk for CAD. In terms of your modifiable risk factors, if you have a high serum cholesterol at above, if it's above 200, you want to work on that because that places you at a higher risk. You have some form of control by trying to work to bring down the levels of your cholesterol. Cigarette smoking places you on higher risks. You can stop smoking if you want to. That's why it's a modifiable risk factor. Hypertension could be treated. Diabetes, physical inactivity places you at a higher risk. Being obese, depressed, or if you're constantly under chronic stress, oral contraceptive use or hormone replacement therapy, and even substance abuse, like someone who's abusing methamphetamines or cocaine, they are at a higher risk for coronary artery disease. In terms of our intervention for this client, you want to carry out some form of health promotion, teach the client or advise or educate the client on the risks of smoking and why he needs to stop smoking. You want him to follow a balanced diet that limits intake of fat and sodium. You want to check his blood pressure and cholesterol regularly. Again, he needs to engage in regular physical activity. Remember, the goal here is reduction of blood pressure and the pulse rate upon exertion. Again, we might need to administer vasodilators. Vasodilators are medications that we want to administer vasodilators. These are medications that dilate the blood vessels. They affect the muscles in the walls of the arteries and the veins, and they prevent the muscles from tightening and the walls from narrowing. So as a result, the blood flows more easily through these vessels. So we can also give aspirin, your glycoprotein 2B3A inhibitors. These glycoprotein 2B3A inhibitors are potent inhibitors of platelet aggregation. So they provide some form of protection from ischemic events, especially in patients undergoing PCI. PCI is your percutaneous coronary intervention, a procedure used to open up blocked arteries. So we'll talk about that. So we can also give beta blockers. We can give angiotensin receptor blockers and even our calcium channel blockers. Again, you want the client to engage in exercise program. Like we said, the goal is reduction of blood pressure and pulse rates upon exertion. Again, we can carry out percutaneous transluminal coronary angioplasty and stent placement. So what happens here? A balloon-tipped catheter. So this is our balloon-tipped catheter. Is inserted under fluoroscopy to the occluded coronary artery. So you can see there's an occlusion in the left coronary artery. So this is your left anterior descending artery or your LAD artery. So it's threaded into that blockage. So this is a blockage here where you have the plaque, and then the plaque is compressed against the wall. So the balloon is inflated, and this will compress the plaque against the wall. And you can see the compressed plaque over here, and the vessel is opened. So the lumen of the vessel is open. Again, we can also give an IV heparin by continuous infusion during this procedure to prevent thrombus formation. We can also give IV or intracoronary nitroglycerin or even sublingual nifedipine. You want to prevent coronary vasospasm. You need to monitor for complications. Complications such as closure of the vessel, bleeding, reaction to the dye, because you know we said under fluoroscopy, so a dye will be used. You want to look out for any reaction. You could also look out for hypotension, low potassium level, and also cardiac dysrhythmias. Again, the healthcare provider will prescribe long-term nitrates, even calcium channel blockers, and also aspirin therapy. We can also carry out coronary artery bypass graft surgery. So here, a healthy artery or vein from the body is connected or grafted to the blocked coronary artery. So you can see this is our right coronary artery, and there's a blockage here, and you can see there a bypass is created using the sphenous vein, or the saphenous vein, sorry. And again, there's an occlusion here in the left anterior descending artery, and a bypass is created using the internal mammary artery. So you can see it has bypassed this area. So it's taking blood from here and bypassing the occlusion. So the indication for this is to increase blood flow to heart muscles in clients with severe angina. Again, preoperatively, what do we want to do for these clients? You want to educate these clients and also psychologically prepare him. We'll need to discontinue medications this client is on. For example, if he's on digitalis, we want to stop that 12 hours preoperatively. If he's on diuretics, we should have stopped this like 2 to 3 days pre-op. And also aspirin and anticoagulants should have been stopped 1 week pre-operatively. So he's going to be placed on medications such as potassium chloride to maintain normal potassium levels. You also want to place him on beta blockers, calcium channel blockers, antiarrhythmics, antihypertensives. We could also place him on prophylactic antibiotics 20 to 30 minutes before the surgery. Remember, digitalis, we want to stop 12 hours preoperatively. I know digitalis is used to treat congestive heart failure and heart rhythm problems like your atrial arrhythmias. It can increase blood flow throughout the body, and it can also reduce swelling in the hands and ankles. So you want to stop your digitalis 12 hours preoperatively. Again, post-operatively was our responsibility for this client. What does the NCLEX want you to know? You need to, the client could be on mechanical ventilation. So there's a client on mechanical ventilation for maybe 6 to 24 hours. So this will be used to assist or replace spontaneous breathing. Again, he might be connected to a chest tubes. So you might have chest tubes that are connected to water seal drainage system. So these are water seal drainage system. Again, we will need to ground the apical pacer wire, and you want to tape it to the client. So remember your pacemaker. So we're looking at our epicardial pacer. So you want to make sure you tape this to the client, and you need to ground it. So your pacemaker uses, so these are pacemaker uses electrical impulses to stimulate myocardial contraction or to depolarize the atria or ventricles. Epicardial wires are used for temporary pacing after cardiac surgery. So pacing is used to treat temporary rhythm disturbances post-operatively. Also, we need to assess pulmonary artery and arterial pressures and heart rate and rhythms of our clients. You also want to manage his pain and give pain relief. You also want to monitor for complications like fluid and electrolyte imbalances, hypotension or hypertension. You are looking out for hypothermia, bleeding, cardiac tamponade, altered cerebral perfusion. So you want to be alert to psychological state of your client. If he's disorientated, if he's depressed, you want to be alert to all of that. Again, you also want to provide activity as tolerated with progress as ordered. So you want to provide activity as tolerated. So you can move from, for example, his feet dangling over the side of the bed to sitting in chair, and then we can progress to walking in the room by 3rd day. Again, you also want to provide guidance concerning long-term care and follow-up. Chronic obstructive pulmonary disease, or your COPD, is a group of conditions associated with obstruction of airflow entering or leaving the lungs. Usually it could be from genetic or environmental causes. Your environmental causes would include smoking or air pollution. So let's look at some of these conditions that are categorized under COPD. So the first would be our asthma. So here you have a normal lung, normal muscles, they are relaxed. There's a normal lining, normal amount of mucus. So this is what you see in a normal client. But in asthma, there's a chronic episodic attacks of breathlessness. So you can see the linings are swollen compared to your normal linings here. There's excess mucus productions and the muscles tightens. So that's what you see in asthma. And to your left, we have emphysema. So those are our normal alveoli, and you can see what they look like in emphysema. So the alveoli is enlarged, and you have air that's trapped in the alveoli. So there's overinflation of the alveoli that results in destruction of alveolar walls. And some of the predisposing factors for emphysema would include someone who smokes, chronic repeated infections, and even environmental pollution. Here on the left also, we have a healthy open airway, and you can see the relaxed smooth muscles. But in chronic bronchitis, which is also another form of COPD, you would notice that the smooth muscles are tightened, they are tight, and again, the airline is what's narrowed. There's also increased mucus production. So in chronic bronchitis, there is inflammation of the bronchi with productive cough. Okay, another COPD would have to look at is our cystic fibrosis. So with cystic fibrosis, what do you see? It's actually a hereditary dysfunction of the exocrine glands, causing obstruction because of the flow of thick mucus. So there's a buildup of thick and sticky mucus in various organs. For example, in the lungs, what do you see? This is a healthy airway, and this an airway with cystic fibrosis. So you can see there's severely reduced airflow, and there's thick and sticky mucus building up in the airway and causing obstruction. So in the lungs, the mucus would clog the airways, and it would even trap germs like bacteria. And this would lead to infections, inflammation, and even respiratory failure. You could also have some effects of cystic fibrosis in the pancreas. So there's a buildup of mucus, which prevents the release of digestive enzymes that help the body absorb food and key nutrients. So what are you going to see in this client? Because of this obstruction by the mucus, you're going to have the client coming down with malnutrition and poor growth. Also in the liver, this same thick mucus can block the bile duct, causing liver disease. So these clients would also in the liver, the thick mucus can block the bile duct, causing some form of liver diseases. So people with cystic fibrosis, they usually have some symptoms such as very salty tasting skin. Their skin tastes salty. There's persistent coughing, at times with phlegm. There's frequent lung infections, including pneumonia, bronchitis. You will notice wheezing and shortness of breath. There's poor growth or weight gain. There's poor weight gain in spite of having good appetite. They usually have these frequent greasy, bulky stools, or they have difficulty with bowel movement. And again, you can also see infertility in males. In terms of diagnostic tests, we can carry out the sweat chloride analysis test, where you will find elevated levels of sodium chloride. We can also carry out GI enzyme evaluations, and we will notice some pancreatic enzyme deficiencies. So in terms of our general assessment of clients with COPD, you will notice change in skin color. They will be cyanotic, or they will have this reddish color. They will also have weakness, fatigue, weight loss. Again, you will notice some risk factors. They could be probably tobacco smokers, or they actually passive tobacco smokers. There could be occupational exposures. There will be, you will notice air pollution, coal, gas, asbestos exposure. There could also be genetic abnormalities. You will see like maybe the alpha-1 antitrypsin deficiency in some of these clients. Again, you also notice use of accessory muscles of breathing. They'll have difficulty breathing. You will notice they frequently change their positions, maybe in the day or nighttime. There'll be cough. There would also be abnormal arterial blood gas levels, your PaO2 and your PaCO2. They would also have adventitious breath sounds. These are abnormal lung sounds that are heard in the chest. They give us clues as to help us diagnose pulmonary or heart diseases. Again, you also notice changes in sensorium and also memory impairment. So in terms of our plan for these clients with COPD, we want to assess airway clearance. We want to listen to breath sounds. They would need to be administered low flow oxygen. Why is that? Because we want to prevent CO2 narcosis that is seen in emphysema. Okay, so what's CO2 narcosis again? It's actually a condition that develops when excessive CO2 is building up or is present in the bloodstream. And when you have excess CO2 in the bloodstream, it will lead to a depressed level of consciousness. So this condition largely results from lung disease, hypoventilation, or environmental exposure. Again, you want to encourage fluids, at least 6 to 8 glasses per day or 3,000 mils per day. You also want to provide small, frequent feedings. We also need to administer medications like your bronchodilators, your mucolytics, corticosteroids, anticholinergics, leukotriene inhibitors, influenza and pneumococcal vaccines. So we want to administer these medications. Again, we would need to use our metered dose inhaler. So this will be our metered dose inhaler. May be used with or without spacers. So this is your spacer. So these are used to deliver medications directly to the lungs. And some of the medications that could be used with these inhalers include your beta-2 adrenergic drugs, like your albuterol, metoprolol, terbutaline, and your salmeterol. So these are some of our beta-2 adrenergic drugs. Again, we could also use corticosteroids like your fluticasone and your prednisone. We could also use cromolyn sodium and nedocromil. We could also give anticholinergics with our inhalers like your ipratropium and your tiotropium. Again, this is important.